The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
Hello everyone. So I work at Royal North Shore and I am currently the transitional nurse practitioner there. One of my portfolios is education of medical and nursing staff. So we have a lot of experience with, or currently getting a lot of experience with, interprofessional or interdepartmental deteriorating patient training. I guess really for us, and what I guess I'd like you to take home is, for us, the mental model that we all try to share is that the team that works together, they should be training together. And so that's what we've really tried to encourage in a lot of our programs and a lot of our courses that we run. So in terms of the courses we run a weekly simulation training in situ in ICU, which is both for the nursing, medical staff and allied health. And then we go up to also full-time, full-day courses, some of them ICU specific, other of them more hospital specific. So for instance, we have a day where we do some of our emergencies such as chest opening, and we involve the cardiothoracic surgeons. We have a day where we go down to CT scanner. Our ECMO course involves both nursing and medical teams. We have a tracheostomy day which also works with allied health, physios, speech path and all the different wards that actually look after trachees. So we do have quite a good program in terms of interprofessional and interdepartmental courses. And I guess there is a few things that we sort of usually come up against in terms of education, the usual barriers. So we've got time, cost, personnel, those who aren't quite as enthusiastic about SIM or getting all together. But there is a few strategies that we have found have been quite useful for our courses. So I guess first of all is making sure you're meeting the needs of the departments that you're trying to engage. So for our SLICE course, which is Simulated Learning in Intensive Care Emergencies, we run down a course down in radiology. So we like to do a dislodged airway down in radiology and make sure that we go and have a chat with the radiology nursing managers and with the chief radiographer to find out what actually they need from us in terms of the scenario. So whether it's about processes that we're not sure of that are meant to happen, or why they're wondering why we do things the way we do it. So having a bit of a chat before you're trying to come and jump into the department and say, hey, we want to use your time and your resources, has definitely been a way of improving our communication and our teamwork for these sort of simulations. I guess it's also really nice with the SLICE program where we get cardiothoracics and the neurosurgeon team involved, because they can also come in and be involved within the debrief. I think that gives us an opportunity to see whether we're doing the right things, so again what they expect of us before they arrive in an emergency, but also it gives us a chance to ask them questions and sort of let them see our processes. It's always also quite interesting to see them on the phone thinking, I'm just going to be talking to Jess on the switchboard, and it's actually one of our department heads from neurosurgery. So again, it's bringing in some of those different techniques about the learning how to communicate within the scenarios and not getting too stressed. We also look at our incidences that occur regularly, so looking at our IMS data, looking at our incidences and trying to make sure that we program simulations to bring up some of those maybe even small little occurrences. So proning a patient is something that we've used simulation, and that we need all our department involved for that one. So there's definitely been in terms of interdepartmental and interprofessional, we're just trying to keep with the mentality, or with, I guess, the culture that we should all be training together, because in the end of the day, we're all in these emergencies together, and that you can always take something from each other with learning. And I guess the really big thing to remember is that it is actually little small steps that can make big changes. So none of our programs started, we're sort of created at the click of a finger, but you do need to think about, okay, so maybe this time I just have a low fidelity mannequin, I'll do what I can with that low fidelity mannequin, get a few people through like an ALS scenario or a simulation scenario of a deteriorating patient, but make sure you keep a record of it. So record what you're doing and evaluate. We have a lot of information from our courses of evaluation and how people feel within the course, and that gives you some ammunition to take it to the people who will give you the money, hopefully, for more resources and more equipment, because I think sometimes you feel like you have to have a big $60,000 mannequin to run some of these scenarios, and really you can have a low fidelity and still get a lot of the learning points and the learning objectives out from these sessions. So yeah, that's me.